Welcome. I'm Susan Grew, and I'm the Foundation Programs Director, and this is the Foundation's medical lecture series, Medicine in Our Backyard. The Library Foundation is completely membership-driven. We receive no outside funding, and our job is to exist to support this library. And we all know what a wonderful library it is, and everything that we do through the support of our members, we do to make this library even better. So if you haven't become a member, I invite you to become a member tonight so that you can join us in helping to support this wonderful library. In the back, you see membership applications tucked inside of our beautiful newsletter, and also our website is inside the newsletter if you prefer to go online and become a member directly. And just to remind everyone, membership comes with a lot of perks, but the newest perk I want to make sure everyone knows about is has to do with our sold-out programs. And many of you probably heard we had Colson Whitehead, the National Book Award winner and Pulitzer Prize winning author. He was here last Wednesday. The program was sold out for months. If you are a foundation member, we videotape that program. We got special permission to videotape that program, and it is going to be made accessible only to foundation members. If you're a foundation member, you will receive an email a code in your email that will give you access to this videotape. But again, that's only if you're a member. So not only do you get to come to wonderful programs like this and know that you're supporting the library and everything we do, you also get inside access to videotapes of our sold-out programs. So again, thank you. And those of you that are members, and I know there are many of you here tonight, thank you very much for your support, and we invite the rest of you to join as well. I also want to thank our generous series sponsors, the late Dr. Ike and Ginny Kempler. These wonderful and generous souls may have left us, but their philanthropic spirit lives on through the sponsorship of this series. So we thank them and we thank their family for their support. On to our program. I am pleased to introduce tonight Dr. Shalini Shah and Dr. Fernando Silva. They will be talking to us about back pain tonight, as you saw. And starting quickly with Dr. Silva, we are happy to welcome him back from Southern California. He got his medical degree at UC San Diego, and I found out tonight he is a fellow anteater, so we're proud of our affiliation. And he completed a residency in neurological surgery at Loma Linda University Medical Center and a fellowship in orthopedic spine surgery at the Shriners Hospital for Children in Philadelphia. And just a quick side note, and I talked to him a little bit, I don't know if very many of you are familiar with what the Shriners do, but their community and philanthropic efforts are felt worldwide, and I know personally some recipients of Shriner Hospital treatments, and they just do wonderful work. So I want to thank Dr. Silva for being involved in that. Dr. Silva's clinical interests are spinal surgery, minimally invasive spine surgery, scoliosis, and deformity spinal surgery. But before we get to Dr. Silva, we're going to start with Dr. Shalini Shah. And before she started her medical career, she spent a year in Egypt training to become a diplomat. So that's interesting. I kind of want to hear more about that at some point, Dr. Shah, but we're glad that you returned to the States to do your medical career with us. She is now the only specialist in Southern California with her unique credential to treat chronic pain in children. She has trained at both Cornell University and Harvard Medical School, and Dr. Shah now splits her time between administering anesthesia for surgery patients and helping children on the road to recovery from pain disorders at UCI's Pain Clinic. She says, "I have the most perfect job. I love what I do, and I could not have asked for anything more. My greatest success is seeing the children thrive." I'm just struck by we are so lucky to have both of you here tonight, and thank you for your compassion and service to the children. Now, without further ado, Dr. Shah.
Thank you. Thank you. Good evening. Does this work? Can you hear me? Okay. So I'm so glad to be here tonight. When I heard about the program, this is something that I've really been looking forward to connect with you, to explain a little bit about what we do, about low back pain, and how to treat it. Is this better? Can you hear me better this way? Okay, great. So my name is Shalini Shah. I'm the Division Chief of Pain Medicine at UC Irvine, as well as the Director of Pain Services for the entire enterprise. And throughout the program, if you do have questions, please feel free to raise your hand, ask me. I want this to be as interactive, as meaningful for you as possible. I have a disclosure. I do have a research grant from Pfizer Pharmaceuticals, but I will not be discussing any of their products. So at the conclusion of this program, we have three major objectives. Number one, I want you to understand what causes low back pain. What are the primary causes? Number two, discuss options for treating low back pain, and then identifying appropriate candidates for treatment for low back pain. So the way we begin is the most basic way of how we treat low back pain. It's a modification of the World Health Organization Analgesic ladder. That means the ladder that we use, the stepwise approach to approach pain. Number one, make an appropriate diagnosis. Number two, the first tier pain therapies using anti-inflammatories, TENS, physical therapy, over-the-counter pain medications. If they don't work, we move on to the second step of the ladder, which is opiates, nerve injections, epidurals. These are things that you've probably heard of before, nerve blocks. And finally, if those fail, we move into more aggressive approaches, which include surgery, implantable drug pumps, spinal cord stimulation, neuroablation. And the premise that I'd like to propose to you today is that perhaps we should be re-evaluating the way we consider the stepwise approach to pain. So let's begin with low back pain. The Institute of Medicine approximates that 1 in 3 Americans suffer from low back pain. So a third of us, at some point in our life, or at least at present, are suffering from low back pain. And sometimes pain can be an implication of an underlying disorder, meaning patients who have cancer, the way they actually first present with metastatic disease is actually low back pain. We do further investigation, we find it's actually a cancer. It could be a segmental problem at the level of the spine, or it could be a degenerative process just as we age. So some common diagnoses that if you have not heard already, you will, are disc degeneration, facet arthritis, disc herniation, sacroiliac joint dysfunction. How many of you in the audience have heard of these words before or have come across it or are familiar with it? Great. Okay, so you know what I'm talking about. And so tonight's program, we're going to start talking about what this means. When you go to your doctor's office and your doctor tells you you've got disc degeneration or you've got facet arthritis, what does that mean? So, how does pain occur? It is way too complex for this meeting, but I can tell you that it is a severely intricate etiological answer. So the way we feel pain is a multitude of different receptors, different neurotransmitters, different nerve signals of different varieties. So I'm going to put that aside and talk to you more from the aerial bird view. What happens at the spine? What is going on for you to understand what exactly is causing your pain? So this is a view of the spine. This is the MRI view of the spine, looking at the same way as if I were looking at the skeleton. Okay? So what we see here is a normal disc. It's a normal disc. The center of the disc is made up of water. The outside is made up of proteoglycans, or what we call collagen fibers. Here we see a degenerative disc. You can see that the shape, the integrity of the disc is abnormal. Here we have a bulging disc. The disc has protruded out and is bulging into what's right behind the disc? The spinal cord. It's bulging onto the spinal cord. Here we have a herniated disc. You've seen that, you've heard of the concept of herniation. I've got a herniated disc. What does that mean? The disc has extruded to the extent that it's compressing the nerve, compressing the spinal cord in some instances. Here we have a thinning of the disc. Here we have a disc degeneration with osteophyte or bone formation, reactive bone formation. And you can see the same thing on the MRI. And the reason I bring this up is because when you go to your doctor's office, I want you to feel empowered. Doctor, show me my MRI. What does that mean? What does a bulging disc mean? How do you see it here? So when you understand these concepts, when you present to your doctor's office, it will be much more meaningful for you. This is an example of the cervical spine, a disc herniation. This is a normal spine with the disc material, and here is your spinal cord. This is an example of a disc that has herniated, where the material that's within the disc has broken through the integrity of the outer border of the disc and now is pressing on the exiting nerve root or the spinal cord. This is an example of facet pain. So facet pain, this is the joint, this is the facet joint that holds up the spine. So the way the spine is connected to each other is called the facet joint. And it's a true joint, just like other joints in our body, the hip, the knee, the shoulder, which means it has a synovium. It has a bag of fluid that protects the joint. But as we age, just like our knee degenerates, just like our shoulders and hips degenerate, so do the facet joints, because it's made up of that same bag of fluid. And particularly, you'll notice this type of pain when you wake up in the morning, you have that joint stiffness in the low back. Extending, any type of extension maneuvers is when we use that facet joint, and that's painful. That's called facet joint arthritis. This is the sacroiliac joint. This is something that you also may have heard. The sacroiliac joint is the largest joint in our body. It's where the spine meets the pelvis, and it's held together by various ligaments. This is not like your facet joint. This is not like your hip joint. This is not like your knee joint. It does not have a bag of fluid. So it's prone to degeneration because of overuse. The bone-on-bone friction causes pain. Usually, the patients who have this type of pain are patients who are overweight, obese, who carry a lot of abdominal fat and puts a lot of weight on our sacroiliac joint. So pregnant ladies typically have this type of pain. So in trying to decipher what type of pain you have, it's really important that the doctor understands the referral patterns. This was a paper that was just published recently in Pain Physician, and it shows that if a patient presents with thigh pain, what is most likely to be causing its pain? Well, if you're in the younger population, 25 to 60 years old, the likelihood that you have low back pain with thigh pain is caused because of the disc. But as we age, you'll see that the older population, most likely back pain plus thigh pain, is most likely caused by the facet joint and a little bit of the sacroiliac joint. However, what about those patients who have low back pain but don't have thigh pain? And this is why it's so important that you give the right description of your pain to your doctor, because it can make all the difference. Here, you still see in the younger population, most likely due to degenerative disc. But as we age, you can see a higher prevalence of the sacroiliac joint pathology and less of the facet. So it's very important for you to tell your doctor, I have thigh pain, I don't have thigh pain, it goes down to my ankle, it just stays in my back. These are very important questions to ask. And of course, any doctor should be looking for the red flag symptoms, making sure that there is no metastatic cancer, making sure that you're able to walk, you don't have loss of sensory, or don't have incontinence of the urine, incontinence of the bowel, because these can be very serious symptoms in which we have to send you to the neurosurgeon right away. So what can I do to prevent low back pain? The best way is prevention. Right? So what I typically tell patients, if you're overweight, if you're above your normal BMI, lose the weight. And it's not just for your health, it's for your spine. The nature of the way we were designed as human beings is not so that our disc can accommodate such a high load. We have to lose weight so the disc can accommodate a normal load of a patient's weight. So exercise. If you smoke, I would suggest that you stop smoking or try to stop smoking. And the reason is because the blood supply to the disc is so fragile. It's so minimal. So a little bit of smoking will stop the blood supply to the disc. And none of this comes as rocket science. Eating a proper diet, taking good sleep, these are all things that are important for good disc health. Well, what are the options when that fails, when preventative measures fail? And this is where we're going to get to the crux of the discussion so that you can bring this information to your doctor's office. So one is physical therapy. One of the things that we try to do in physical therapy is send you to the physical therapist to do some core strengthening. The reason is when you strengthen the core, you take pressure off the disc. It helps the back. What about medications? You'll see a plethora of ads on TV, on the Super Bowl, a whole host of ads nowadays on appropriate pain medication, right? So we have antidepressants like Cymbalta. We've got nerve medications like Lyrica. We have muscle relaxants. We have opiates. You've heard a lot of news lately about the opioid epidemic. We have steroids. We have anti-inflammatories. And the reason we prescribe what we prescribe has to do with the mechanism of pain. In a very, very brief sense, when we have a noxious stimulus, you put your hand on the stove, what happens? The pain signal travels to the spinal cord and up to the brain for perception. But that's not compatible with life. Every time I take a step, then practically I'd be in pain. That's not compatible. So what the human body has are descending fibers that downregulate, that stop the transmission of pain. And one of those tracks happens to be the depression and anxiety track, which is why we give antidepressants to you for pain. It's because it downregulates the perception of pain. So what about opiates? We talk about painkillers in the news. There's a balance nowadays between opiate phobia, which is not using painkillers, versus using quite liberal painkillers. And it really depends on the patient. This is just a slide from the CDC showing that opioid analgesics, opioid pain pills, are the #1 cause of death in this country, more than cocaine and heroin combined. And you can see that the deaths, which is the yellow line, completely superimposes the number of sales of narcotics in this country. I just wanted to share a little bit to our public here in Orange County about what we're seeing in Orange County. This is data from the coroner's report in the Orange County coroner's report about drug and alcohol overdoses in our county. And what we're seeing is that most of the deaths, the dark purple is the highest number of deaths. The highest number of deaths in our county are actually our coastal communities. Seal Beach, Costa Mesa, Huntington, Dana Point, Newport not so much, San Juan Capistrano. Most of the overdoses that we see in this county are actually our coastal communities. We presumed it might have been Santa Ana, Orange, that area, but it's actually our coastal, wealthy, affluent area. The patients who are overdosing are primarily male between the age of 45 and 65, non-Hispanic white males. And primarily the reason for overdoses in this county specifically, is accidental. About 75 to 80% of patients who die in this county are from accidental overdoses. Only 15 to 20% is because of intentional overdose. The same thing here. By and large, the reason for the overdoses in this county are due to prescription pills, not so much illicit substances like heroin or cocaine. Again, because of the fact our hospital utilization and the amount of patients we need to take care of has increased. So, what is the side effect? Why don't we prescribe the painkillers as much as we used to? You probably have seen that from your doctor if you're on painkillers. The reason is because of the side effects. What we've learned over the last 20 years of research is that patients actually have a lot more side effects with medications. Sedation, drowsiness, tolerance, it actually can make your pain worse over time. So what about pain interventions? The option then, remember, we're going up the ladder. The next step on the ladder is, what about nerve injections? Well, the risk of nerve injections of nerve injury is about 0.03%, very small. So we have a case here where we don't want to get patients addicted to pain medication. Perhaps they can't tolerate the sedating side effects of antidepressants. And so let's talk about injections. What are some of the options we can use that are non-medication based? Okay, the first is going to be an epidural. How many of you have heard about an epidural before? Yeah, everyone has heard about an epidural. The way an epidural works, it's the same technique as if you're going into labor. For pregnant ladies who have a baby, it's the exact same technique. We take a needle, we put an injection in the spine, and instead of delivering numbing medication, we're now injecting steroids. So we've been using epidural steroid injections for over 40 years. It was first described in the late 70s, early 80s. And this type of pain is for patients who have that midline low back pain or that sciatica symptoms because of that nerve root, that disc that's compressing the nerve root. Right here. So how do steroids work? We hear a lot about steroids causing diabetes, causing whole sorts of complications. How do steroids work? And why do we give steroids? The reason is because when a nerve is damaged, when the disc herniates and presses on the nerve, What happens is that nerve is irritated, and when a nerve is irritated, it becomes swollen, or what we call edema. So there's edema around the nerve, and it continuously fires erratically. So when you have an injured or damaged nerve, one thought is to decrease the amount of noxious stimulus that is around, that inflammatory cascade that surrounds the nerve, to decrease the firing of the nerve. And so that's the reason we give steroids. If you come down on the pathway of how steroids work, you'll come to how aspirin works, how your Advil and your Motrin works, but that's lower down the cascade. Steroids work so high in the cascade, you're going to get any type of inflammation downregulated. So that's how effective it is. This is an example, and if you ever have an epidural or will go into the office to get an epidural, ask your doctor to show you these images. This is what we do when we do an epidural. This is the spine under X-ray, and you can see the needle entering the epidural space. Okay, so it enters the epidural space, and once we're in the epidural space under live X-ray, we inject the steroid. This is an example of using a modified technique where we're just trying to isolate that nerve. You have a damaged nerve root, L4, L5, and that's the nerve root that's damaged, that has that edema, that has that inflammation, and we just want to put steroids around that nerve. We just want to target it. And this is an example of the doctor putting the steroid right along that nerve root. This is a targeted approach. This is not systemic steroids. This doesn't cause weight gain. This doesn't cause the diabetes. It's targeted. Sometimes we have patients who we encounter who have had spine surgery. And this is why it's really important that you go and talk to your doctor and ask, Doc, what about other options? I've had a fusion. How are you going to get that needle in there? Is there a safer way to do it? There are other approaches. This is an example of a coccyx injection, or going through the caudal space. So going a little bit lower, but still able to get that epidural space. So the reason I show this to you is that when you go to your doctor's office, you know the questions to ask. What about other techniques? I read about this. I heard about this. Am I a candidate for this? And I hope you take these images and these thoughts and you hold them with you as you go to your doctor. So, very briefly, facet injections. These are patients who have that facet arthritis. So patients who are at 60, 70, 80 years old, even sometimes younger. These are patients who have low back pain, but it's a band-like pain. They say, Doc, I just had this band-like pain. It's worse in the morning. It's stiff. Sometimes it goes to my buttocks, but usually not. If it's in the neck, and how do you know you have arthritis of the neck? You can't change lanes. Every time you try and change lanes, you got to move your entire body. That's called arthritis of the neck, okay? And again, this is that facet joint that we talked about, the arthritis in that joint. So, very quickly, what do we do? This is an example of a facet injection. We block the nerves that cause pain to the facet. And then I examine you about 15, 20 minutes in the recovery room. And I really put you through the ringer. I bend you, I twist you, I extend your back, and you should have pain relief. You should actually have no pain. And patients typically say, Doc, I have no pain, or I have 80% relief of my symptoms. And if that's true, there's a more permanent solution for you, which is ablation, which means that we actually can burn the nerves that cause the pain. It's not permanent. These nerves are small, they will regenerate, but at least it gives you temporary, up to a year's worth of relief so that you don't have pain. And you don't have to take medications. And you don't have to come into the doctor's office every so often for injections. This is an example of doing a facet ablation. We put the needle near the facet joint and ablate the nerves. This is an example of the machine that we use, just to give you some correlation. And we burn it about 80 degrees Celsius. And at 80 degrees Celsius, we're able to stop nerve propagation. This is an example of a sacroiliac joint injection. That large joint I was talking about, the large joint in the body, we can put steroid into that joint, targeted approach, and alleviate the pain. And I can speak to this because I've had this myself, and it really does help. It's targeted. You don't need medications. You don't need to take nerve medications, things like that. It just will alleviate your pain. Sometimes we have to repeat it. The pain does recur, but by and large, patients are very satisfied, and they don't have to take medications. So, does injection therapy work? By and large, the evidence says yes, but if we pick the right patients, we don't offer injections to all patients. You have to be the right patient. So the evidence is good for patients who have pain, low back pain that goes down to the leg, for lumbar epidurals, for lumbar ablations, the facet ablation, and as well as for neck injections. But for patients who have low back pain that doesn't radiate anywhere where epidurals work, the evidence is fair. So this is important for you to know when you go to see your doctor. Doc, what's the evidence? How do you know this will work? What's most likely to be successful for me? Very quickly, I'm going to talk about the last tier of the approach, which was spinal cord stimulation. We have a subset of patients who have had injections, who go on to have surgery, and still complain a little bit of pain after surgery. It was actually first described, this concept was first described in Greece in 63 AD by a patient who had gout. And the therapy at that time was go stand in the ocean, put your feet on the torpedo fish, and your pain will go away. And it's true, that's what was described. And the reason is because the torpedo fish sends quite a bit of vibratory signals. So the patient felt numb, practically, from the pain. So this is an example of the 1700s torpedo fish, an example of the 1960s torpedo fish, and this is where we are right now. This is our torpedo fish. It's called a spinal cord stimulator. The concept was described more formally in 1965 in a paper in Nature. Beautiful paper, I think only about 3 or 4 paragraphs. Elegant description of how this works. The way it works is that the concept is we send vibratory signals to the spinal cord, which will block pain signals from entering the spinal cord. Brilliant. This is how your TENS machine works. If any of you have had a TENS machine, it's the same concept. Your torpedo fish is the same concept. We send vibration so that pain signals don't enter the spinal cord. So this is an example of a spinal cord stimulation. We use these electrodes, we implant them in the spine, in the epidural space, and we put a small little battery in you, and you can control the stimulation high, low, up, down, left, right, through your remote control. And nowadays the technology is so good, you just use it on your iPhone. Yeah. So as a neurosurgeon, we'll put in paddle leads, or you can put in small percutaneous leads. Either way, this is how small the battery is. And some of the small batteries, you won't believe the technology that's coming out. It's just skin deep, just size of an inch or 2 inches, some of the new devices that are coming out. So there are a lot of options out there to treat pain, particularly those patients who have pain, who have tried everything and don't know what else to do. So we know that it's very good for pain, anxiety. We actually used to use it quite often for patients with heart problems who have angina, who are not candidates for cardiac bypass. It actually helps patients with their blood flow. It helps patients with the blood flow of the lower extremity for those patients who have vascular disease. So we actually use spinal cord stimulation a lot for non-pain problems. So this is an example of the spinal cord stimulator. Back pain, leg pain, ischemic pain, so that means pain because of low blood flow, and failed back surgery syndrome. So the outcome is level A for most of the things that we use it for. By the way, so you know, level A is the highest level of evidence that we get in medicine. You want to go to your doctor, you say, Doc, what's the evidence for this? You want level A evidence. For most things that we do are level A evidence. So we would not put this in you. You would not be a candidate if you have severe anxiety, depression, infections, you have a pacemaker, you have a defibrillator. You probably won't be the best candidate for this. This is an example, again, of the device that we have. And this is a patient undergoing a trial in implants. Here you go. These are the electrodes that you can probably see under X-ray. They're just sitting next to that spinal cord, giving imperceptible, very, very small vibration signals to block the pain signals. This is an example, again, of putting it in. And all the things that we could do. We can use it for the heart. We can use it for the legs. We can use it for the GI to improve gut function. A lot of options out there. And, you know, this is why I'm so happy to be here, because, you know, when you think about low back pain, you think about, oh gosh, I'm just going to have to suffer with it for the rest of my life. It's part of getting old. It really isn't. You should know the new technology that's out there. Medicine is changing. There are so many options out there for you. I always show this diagram because I know what happens to patients in pain. You have pain, you don't want to move. Because you don't want to move, it you get anxious, you get depressed, you don't want to see your friends, you don't go to the mall, you don't go out for dinner, and then the pain gets worse. And so we really need to block the pain cycle. This is why I get up and do what I want to do, because I don't want you to suffer. I always say that pain is inevitable. We will all have pain at some point in our life, but suffering is optional. We don't have to suffer. There are so many options for you. And I hope through this talk, I'm able to keep you motivated and believe that there are better options for you. So we talked a little bit about the interventional options for pain. We've got, and the different causes of low back pain. We talked about epidurals and facet block and sacroiliac joints and nerve blocks and things like that. A little bit about where we practice at UC Irvine. So for the community, we're just down the street on the UCI main campus. This is the Gottschalk facility, for those of you who don't know. We have same-day access, so we usually get our patients in the same day. And if you just want to learn more, if you're just interested, you don't necessarily have to have a problem, but sometimes maybe you want to learn a little bit about what we do. We have a website here. Or you could just call us, and we'd love to invite you over for dinner or cocktail or coffee, 949 UCI Pain. And we typically have patients come in just to tour the facilities, to know what we do, to get an idea of how we do it. Feel free to walk on by. We also have an office in Orange, which is at the Medical Center of UCI. And we have a facility in Tustin. Great parking. It's a state-of-the-art facility, beautiful, family-friendly. The kids love it because there's a playground in the middle. And we have a psychologist, a neurologist, an entire team with us over there. And that's about it. Any questions? Okay. Oh, we're going to do questions later. So then I'll pass it on to Dr. Silva.
Thank you. All right. That's good, Brenda. Good evening. Thank you for the kind invitation. Thank you for being here. I guess you heard a lot about pain already, so what I'm going to do a little bit here is review for you some of the things that she has said, but go into more of the surgical techniques that how we help people with back pain. I did study a lot of spine surgery with children, but also in adults. I did a little more training at Northwestern University in Chicago and Washington University in St. Louis, so I don't see that many kids here, but so they rest assured. All right. I'm Fernando Silva. I'm a neurosurgeon, but I'm also trained an orthopedic surgeon for spine surgery. So the idea is here to talk about when does back surgery really help for back pain? When does it really work? A few numbers here. The back pain happens at any age. I mean, we see kids with back pain and people in their 40s, 50s, up to 90s with back pain. And it is interesting that it is the second most common symptom-related visit to a physician, to a doctor. 80%, I mean, that's amazing, right? Yes, 80% of all Americans have back pain at some point in their lives. And that's about 20 million people. I don't want to put anybody on the spot, but I guarantee you some of you here have had surgery. But the interesting thing is that 95% of these people, surgery is not even needed. Yet, 5% of the patients that needed the surgery, 50% of them think that surgery is the only cure. And you just heard Dr. Shah talk about options of not having surgery, and they work. So the question is, when do they really work? Well, let's go take a step back. When you go to the doctor, what's the problem? What are your concerns? What are your symptoms? So the idea here is to sit down with the patient and spend time listening and talking to them to figure out where the problem is, if you can figure it out, and if there's a problem, can you address it either with other options, pain management, or surgical care. So pain can come in many flavors. It can be sharp, dull, achy, or all of them. Usually sharp pain refers to nerve pain. Achy pain is usually bone pain, a fracture, a degenerating disc around the bone. And I'll show you some examples of this. Tingling or numbness, which is what we call in medical terms paresthesia. That's usually the nerve kind of beginning to be offended. And your legs can be tired. You walk a block and you say, oh, doc, my legs really hurt. What's going on here? And I'll explain to you what that means. And then weakness. And weakness can mean you're feeling tired, just cannot really walk or hold a cup of coffee or this kind of things. And then another thing is not the way you look. And I'll show you some impressive pictures of how this deformities of the spine can create pain and how we correct them. All right, so then, let's see, there you go. So a little bit about anatomy. Where's the problem, you know? So here you don't see, but back here we would have back muscles Then you have back and hip joints, and we heard a lot about hip injections and facet injections, and they are very, very helpful, very useful actually. And then you can have leg pain. Here you see in the yellow, the nerve. This we call holes of foramen or foramina for many. And when this gets narrow, that's where you get nerve pain, leg pain. As the disc begins to degenerate, then that's where you begin to develop back pain. And again, it's sharp, dull, achy. We need to find out what the problem is. And then, of course, narrowing of the big canal, where the big nerves are going here, that causes both legs to hurt. And finally, deformity, and that can give you both back and leg pain, usually back pain, but both can happen. And then, of course, all. So, I'm sorry, oh, that's terrible. Oh, sorry about that. It's all hard to read there on the red. I thought it was going to look good. But what I've listed here is the 3 categories in general of things that can give you problems. Muscle spasm is in green because you have a green light. You don't need me. Go home. The next one is facet joint arthritis that we heard about. And here you begin to kind of say, well, no, don't go home so quick. I got to call Dr. Shah, see what she can do for us. And then the rest here, and I'm sorry you cannot read them very well, but would be broken back or a fracture. As we get older, particularly in women, and men are not immune to this though, the bone gets weak, and you can develop something called compression fractures, and they can be very, very painful. And the problem is, as we get older, also we hunch. And so bracing those fractures becomes difficult, so we have options to help you with that, and I'll show you. Then you can have a herniated disc that can cause you leg pain. You can have degenerated disc that can give you back and leg pain. And then a slip vertebra, which is called spondylolisthesis, just a slip vertebra, and I'll show you how this works. And then narrowing or stenosis. Stenosis is a fancy name for narrowing. And then the scoliosis. Now, scoliosis, let me say a few words about that quickly here. In children, we do scoliosis because of their deformity. They don't like how they look, and they're going to get worse. In adults, we do surgery for scoliosis, but also for the kyphosis. And studies have shown that if you correct the scoliosis and kyphosis in adults, they actually do better than children. Their quality of life is significantly improved. These are big surgeries, I understand that, but people are very grateful after they go through these things. And I'll show you pictures and cases of this. All right, so back to the green deal here. So back muscle spasm, what does that mean? Well, basically, you back gives out and you stay in bed all day. That's usually a muscle pain. And the back feels heavy, tight, and you have limited motion. You don't want to really move. What it would do for this? Simple physical therapy, muscle stretches, and aquatherapy. I love aquatherapy. I mean, I think it's one of the best things you can do for yourself. And if you have a pool at home, just get in it and move around. The idea is that water holds you as buoyant, right? So that's the idea there. And then trigger point injections. Then we begin to do facet joints. Now here's Dr. Shah show you some of this anatomy. Here the back of your back, right? Back of your back. And here you see the facet joints being injected because it's all degenerated and arthritic. And unfortunately, after age 30, this begins to happen, no matter who you are. You can see a healthy joint here, but this one has a lot of arthritis. Before I move on I want to show you a little more anatomy here. This is like I said, the back. This is called the lamina. And a lot of you, I'm sure, had heard the term laminectomy. And I will show you a video clip of a surgery of how that's being decompressed. Basically, when the back gets narrowed and your legs hurt when you walk, what we do then, we shave that bone off. And underneath that bone, there's ligament, like a rubber band, that also pushes on the nerve. So we got to get all that out. And a lot of times, it's not necessary to perform fusions. And I'll show you how we do that, too. All we need to do is shave this off. All right, so then here's the joint. Now we're going into the yellow. We're kind of not going home yet, right? So like she told you, there's a biggest joint in the body called the SI, for short for sacroiliac joint. It's right here. And I cannot tell you how many patients I've seen. They come to me and say, doctor, I have back pain. Okay? And then, of course, you talk to them, and they explain it to you, and then you go examine them. You touch them right there, right here. And lo and behold, it's the joint pain, right? And they were told that they needed surgery. Spine surgery, actually a big deal. And that's okay if you need it, no problem, we'll take care of it. But really all they need is an injection. And here you can see the patient undergoing an injection. The injection will do 2 things. Number 1, it will help us in the diagnosis, give you some help, and eventually then we can go in there, or she can go in there and do an ablation. What they do, they put a little needle in there, some current in their little nerves, here called the cluneal nerves, that they then can burn. And the nerves can grow again because they're, like she said, very small nerves, but you can do it again. Now, if it's still hurting, now we have a new option, and this is through a small incision here. It's called an SI joint fusion. What we do is we put little rods across the joint and try to immobilize the joint so it doesn't hurt anymore. It's called SI joint fusion. It takes about 30-40 minute procedure, and sometimes you can go home either same day or next day. Depends on how you're feeling. And here you can see an X-ray of the joint. This is the joint before fusion. Here's after fusion. Okay? All right. Now we move to what I told you, the fracture, so your bone can break. Here you can see, and so the way we deal with this is a procedure called KYHOPLASTY. It's been around for almost 20 years now, and it works really well. The idea here is that the bone is fractured, it's unstable, so we put some cement in there to make it more stable. It goes like this. We put a little cannula in there, put a little balloon in there, blow it up, so we make a cavity inside of the fracture, and then fill it up with cement, and we do this on both sides. Here's a surgery I did many years ago, and you can see how we put the cannulas in there on both sides of the vertebra. The head is here, the buttocks is here, and here's the back, and through this cannula, we inject this inflated balloons, deflate them, pop them out, we have a cavity, and then through there, we also are able to instill the cement. And you can barely see it here, but this is actually the cement in that cavity. Now, the reason why I have this is to remind me of something important here. So many people call and say, do you do minimally invasive surgery? Yes, we do. But we also do other surgeries. What I'm trying to say is that it's not one thing fits all, because sometimes you need a little scar for minimally invasive, and you see that here, but sometimes you need a little bigger scar or a really big scar, and I'll show you a really big scar. So it's really what you need. It's not what I can do, right? Does that make sense? All right. So I want to point out to you that some people need this, some people don't need this, and some people don't need anything, right? And that's why we're here tonight, to learn about that. So back to now we're going into the surgical realm of things. The herniated disc, what's happening there? So most people herniate the disc when they turn and they bend. People will say, I heard a pop, doc, now my leg is burning. But believe it or not, a lot of times we can help you with little injection. Makes you feel better. You don't have any more pain or weakness, move along. If it recurs, we can do that again, and then we can talk about surgery, particularly if your leg is getting weak. Usually the cause is probably only in one leg, and you can see here the disc torn. Here's the big nerve, the sciatic nerve. That's what people say I have sciatica. You hear that all the time? So the disc is compressing on the nerve, and that causes the problem. And you can see here the disc herniated. This is the back of your back again. Here's the belly. This little square is the vertebra, and the gummy bears, I call them, they're the discs. And unfortunately for us, the human body doesn't come labeled like this. Of course, this is radiology labeled that for us. So L1, L2, L2, L3, L4, L5, and S1. Usually we see those herniations there. All right, the next order of business then now becomes less as simple as now is a little more complicated deal, because what happens is the so-called stenosis. Here, patients complain of back pain, pain on the back of their legs when they walk. And they tell you exactly, they can say 200 meters, exactly. The trick here is to be careful, because there are blood vessels that go here, and they give you the same symptoms. And so you got to learn to differentiate the patient who has a nerve pain versus pain coming from their circulation. And there have been cases where people had surgery for circulation problems on their back, and they don't get better. Guess why? Because that wasn't the problem, right? So you do have to be very careful when you talk to your patients, of course. So what happens here in the cartoon here, excuse me, you see that, by the way, the spinal cord ends here, the nerves come down here, and then the stenosis begins to push on those nerves. And why do they get pain? Because when you push on the nerves, you're pushing on the blood supply of the nerve. And so the nerve doesn't like it. It says, I don't like this, so it tells the brain, pain, right? And here you see the MRI. It's supposed to look like this. See the difference, the narrowing? And again, these are vertebrae, and these are these are degenerated discs, actually, already, what I call the gummy bears. And the patients classically take you, we call it the shopping cart sign. They will lean on their shopping cart, or they just lean forward. And why is that? Because when you lean forward, the spine, it opens, it makes it bigger, so the symptoms get better. But as soon as they go back, guess what? Symptoms come back. Typically, we'll try some epidural steroids here, injections. If it gives them help, great. If it doesn't, then the next deal would be surgery. And so the surgery entails basically making a bigger incision here and removing all the bone on the back that we can. Now, we can do this two ways. We could do it open, or we can do it minimally invasive. And there's reasons why we can do one or the other, but those are your options there. A lot of times here, we do not need to put screws. We do not need to do a fusion. And I've see a lot of patients that get the decompression, the screws and the fusion, but a lot of times that's really not necessary. But I'll show you when it is necessary. So we talked about joints, we talked about herniated disc, we talked about stenosis. Now, back pain can also come from degenerating disc. And again, that's a pretty healthy disc, that's okay. But now here, this disc could be causing you problems. The trick here is to figure out if that's what we call the pain generator. And I'm gonna repeat it again, because it's very important. To have successful back surgery, you have to know where the pain or the issue is coming from. Otherwise, do not do it, right? Makes sense. Why would you wanna do something and you're not sure about, especially if it's your back? And the problem is, a lot of times, once you have one back surgery, you're probably going to need another one. It's just nature of it. So be sure you need the first one. So here's what we call degenerative disc syndrome, and they can give you back pain. Usually it's an aching, nagging pain, can in both the buttocks and sometimes part of the leg. Again, treatment, back strengthening, aquatherapy, which I love. We also talked about weight loss. Why is weight loss so important, by the way? I'll tell you why. Because if you think about it, if you hold something close to your body, like even a 5-pound weight, it's good, right? Now try holding it away from your body. What happens? You tilt. Well, you don't want to fall forward, so you start pulling back. The back muscles are going to get tight, they're going to get tired, and you're going to know it, right? It's the same principle. Now you have a big belly, it's going to tilt you forward. So what do? You're going to walk around pulling back, and so eventually at the end of the day, you're hurting. So that's one of the principles of having of being lean. Also, studies have shown that the bigger you are, the more propensity for infection you have after a surgery, and it happens. So watch your weight. The other, okay, let me go back here. So that's one condition. The other condition, and I'm putting these together because the surgery is kind of similar, it's a slip vertebra, what we call spondylolisthesis. The vertebra slips and that pinches the nerves. So the way we do that is we unslip the vertebra. Now we got to put screws because we make the spine unstable, and then we got to fuse it. Fusion basically is welding the spine. We're spot welding it, okay? So typically here, again, the same, note the pattern here. Same thing, physical therapy, epidural injection. Bracing here, though, doesn't really work. And then eventually we do spinal fusion to stop movement to protect the nerve. So spinal fusion, as I said, is welding. You don't want the motion. The motion is causing the pain. You're not liking it, so we do have to fix it. And here's the slip vertebra. So here's the low back. See how the one block. See how nicely they're lined up? And now this guy slips on top of this guy. See the difference? In the MRI, you see it again. It's a lady I did about 16 years ago. I remember she was so happy because I made her taller. I said, how's your back pain? Don't worry about my back pain. I'm taller. I said, okay, lady. Yeah, actually, I still have, she made me embroidered a beautiful dragon I still have in my office. Sweet lady. And so how do we fix that? Well, the first thing we do, we put screws. When we put the screws, we're able to control the spine now. We lift it. As we lift it, we pull that slip back and makes this taller. Then we remove some of the bone, and we're able to put, you don't see it here, those little dots are, well, I'm sure you heard of this, cages, and we pack those with bone. The idea is then to fuse these two pieces of bone and also to fuse on the side of the bones. Now, the last part of this is the deformity is one of the things I love doing the most. I don't know why, because they're the most complicated, most challenging surgeries you can ever do. It takes years to do these things, but they're very rewarding, especially in the adult population. Patients are so grateful. So a few things about this. Adult scoliosis exists in about 1 to 10% of the time. They usually, if you look at people over 60, about 30% will have scoliosis that never had it. So why is that? This kind of scoliosis is different than the child, because in the child we call adolescent idiopathic. Idiopathic means we just don't know. Here what happens is, as you can see in this cartoon, the facets that we've been talking about, and they degenerate. The spine becomes unstable, it begins to bend. And it can be very, very, very detrimental to the patient. And you can see this 46-degree curve. We usually operate on curves up around 30 plus, but that's not the only thing we look at, by the way. Rarely you see it before age 40, about age 70, most of the time. And the bigger deformity are less common for obvious reasons. In children, usually young ladies are affected more than men, but in our age group, it's too late. We're all treated the same. And the studies have shown the 7 and 8 health-related categories, scoliosis patients were worse than matched controls. What does that mean? That if you take two people, one has scoliosis, one doesn't, the one with scoliosis is much better off than the one without it. But the good thing is, that, like I said earlier, they do very well with surgeries, but you have to be sure that that's what you need. And the usual complaint is mostly back pain, but they can also have leg pain. This is a patient I did a long time ago, and she had, I think 13 or 14 operations. They went through the side, through the front, through the back, and she was in a lot of pain, taking a lot of morphine. I'll show you a clinical picture of her and how she was so bent that she had a special chair that she had to use to sleep because she couldn't sleep. She had two beautiful little babies that she couldn't hold because the pain was just too much. And you can see here her curve. The curve wasn't so much the problem as, see, her head is over here. The head belongs over here. So she was tilted so forward that it's causing her so much pain. So we kind of fixed that curve for her, and the more important thing is you see we realigned her there. Sorry, they're a little fuzzy, the slides there, but that's the idea. So in conclusion then, back is the second most common reason people seek medical attention. Evaluation really starts with talking to you, the patient, because if I cannot get a sense of what the problem is, I have no business touching your back. And I see a lot of that being done, and it's too bad. You really must find out what the problem is. And then we do the workups. Every patient wants, where's my MRI, doctor? Well, we got to talk first. We got to see what's going on, right? Maybe all you need is an injection or some non-surgical treatment. And typically, when you don't have any neurological problems, conservative care is always the better part of valor. And please be sure that whoever does your surgery, whoever you talk to, has experience, knows what they're doing, and is going to give you good follow-up because you become family members. We're in it for life. It's very, very important. All right, and that's about it. Thank you.
I think we'll take some questions and maybe both doctors, if they wouldn't mind. Do you have to take the question?
Yes.
I have a question. Not asking for advice.
Sure, so basically you ran for a long time. Now you have a degenerative disc at 4 or 5?
No, I got a herniated disc.
A herniated, but it's 4 millimeters. People put a lot of emphasis on those numbers, and I hear it all day long. The number is meaningless unless you take it in the context of how much room you have around that disc. If you have a lot of room, right, it doesn't matter. But if it's little room, that 4 millimeters is huge. So so number one, can you live with this? Because if you can, I would. If you cannot, then you have to sit down and we have to go through all these questions to be sure it's either mostly back pain, it's mostly leg pain, because the surgery is so different if that's the route you want to go. Then it could be just the nerve, so it could be a matter of just opening a little bit of the back and shaving some of that bone off and taking that little piece of disc off. The alternative, I don't know how long ago were the epidurals, you can also have another round of epidurals. Is that something you would consider?
You can do another round of epidurals, but I'll be honest with you, because you have primarily leg pain, this is the time I would probably refer you to a surgeon. Perhaps have them look at you, look at your imaging, see what the
Well, I've gone to a neurosurgeon. He was the one that prescribed 2 rounds of
epidurals. Yeah.
Good.
And said, I don't know if I've ever been doing it.
How long have you had it for? I'm sorry if you don't mind me asking.
6 months.
6 months. So the studies have shown that over time, at least over a year's time, and eventually 5 years and 10 years, surgery versus conservative treatment really makes no difference. The problem, what's that?
I heard that too.
Yeah, the problem is some people cannot tolerate and wait a year for the pain to get better. That's why they have to have the surgery. In your case, I would tough it out until you cannot deal with it, and then visit back with your surgeon, circle back, and maybe, I don't know if you have an MRI, maybe do an MRI, maybe repeat an MRI.
Yeah, okay.
That's what I would do. Make sense? Okay. Yes, ma'am.
I have heard that as we get older and our disc, whatever stretch that was supposed to be, now they're kind of floppy.
They buckle. They buckle, right? Yes, and so, okay, that's true.
Is that true?
Very true. And so that causes what I was showing, stenosis. In that situation, if you're symptomatic from it, that's easy enough. So we could go back in there. You see when I was cutting that little rubber band, I called it the ligament? Those are the ligaments. So because the ligament in the back is taut, as you lose weight, as you lose height, the ligament buckles and then has nowhere to go, so it pushes on the nerves. So we go back there, open it up, and take it out. There's another procedure where you can put a little device in between the vertebra, and you tighten it, and it tightens, tightens back the ligament. That's an option. Sometimes that works, sometimes it doesn't, but that's an option too.
And also, I wanted to ask you
Sure.
about the kyphoplasty.
Yes.
Does that have to be done within a certain amount of time from the compression first happening?
It's best if you do it acutely within the next, I don't know, few weeks. But I've done them when past that time, and people have gotten better. But it's better to do it acutely. Now, be prepared, though, you might need more, because the idea is we put in cement, which is very strong. So the other vertebrae are going to have to feel that weight, and they can compress. So be sure your surgeon is going to be around for a while. Yes?
For the fusion surgery, what's the post-operative loss of range of motion? And like,
Sure. Excellent question, yeah. In fact, somebody asked me today in the office when I was seeing patients. Yes, I'm sorry, sorry about that. The question was, after you do a fusion surgery, what is the lack of range of motion that you lose, or the range of motion that you lose? Usually it's about 5 degrees per level. Per level, yes sir, yes sir. But if you do a few of them only, like I showed you, it's imperceptible, because you have the other kind of like you're like a slinky. You have other parts of the spine that will accommodate for that. Now, the interesting thing is, what about that lady that we fuse all the way down, right? What happens to her? Well, people can still bend at their hips. And we teach them, we go through a program of physical therapy and occupational therapy of how to accommodate part of their daily living after a surgery like this. So in the short one, about 5 degrees per level, it's kind of imperceptible. On the long ones, now you are really fused, but you can still use your hips, your arms, and their modalities we can teach you to accommodate your lifestyle.
thank you.
Of course, you're welcome.
As if it was your whole body.
Of course. So the first question is about using stem cells for disc regeneration, right?
And I've had some golfer people that I know have used stem cells harvesting.
Sure, for disc. And then the second question was about finding a good doctor, is that it? Yes. Okay. The first question, I do not have experience. I'm not going to say I do, because I don't.
It's also from the other.
So I have no experience from that.
So we actually are in the process of starting a clinical trial at UC Irvine using stem cells for disc. So there are multi-center studies, us at UC Irvine, UC San Diego. We don't know the evidence yet, and that's why it's still in the clinical trial phase. So
You do it?
not yet. No, we're still waiting to get a research grant for it. But we don't know the evidence. So what is the evidence for stem cell in other portions of the body? It depends on the stem cells that you use. Are you using amniotic, bone marrow? It depends on the stem cell. Stem cells is a very global term, but you really have to be specific in terms of the cells you're using and the scaffolding and things like that. So we don't do it currently, but there are a lot of clinical trials that are going on, and we're hopefully going to be one of them.
What questions would you ask before doing something like that?
Before doing stem cell, you want to know, first of all, the doctor, their success rate, how they do it, how do they perform it, where do they get the cells from, do they do their own harvesting, do you get the cells from an outside company? Those are the questions to be asking.
And then criteria as far as picking a doctor, how would you judge?
You know, this is something, it's funny because we go through this even between my colleagues. How do you find a good doctor? Yeah, you need an OBGYN or you need an internist. How do you find a good doctor? And really, it goes back to word of mouth. I can't find...
Sure.
I can't think of any other way. I go and I ask my colleagues, you know, doc, I just saw a great internist, a great cardiologist. Who was it? And I keep it in my mind, and I give that referral to my patients. You know, when you hear about a good doctor, you keep them. You keep them with you. You see them. We work with them. I see great surgeons, so I know who's good and who's not. But I'm fortunate to be in this field. But apart from that, it's really word of mouth.
Yes? So the question was, before you undertake a fusion surgery, right? We have patients go through physical therapy, aquatherapy, weight reduction, and so on. And how long do we do that for until we say, well, that's enough, right? So at least 6 weeks trial. The weight loss is dictated by something called your BMI. And that's a number we calculate based on your height, your age, and your current weight. So that being said, it's about 6 weeks. 6 weeks, and some people feel better. Now, I'm sorry?
So it's like a percent of your BMI that they lose that you.
They're target. They're for age groups. There are certain targets for your BMI, and that's what we target for. And so that's what we do. Now, I want to make a point about back pain, though. If you go, in my experience, I never tell somebody, I'm going to take you back pain 100%. Because the idea is to make your pain better. Now, I've done surgeries where people say, Doc, I have no pain. I say, well, great. That wasn't the deal. The idea was to try to make it better. And that's what you're striving for, to better your life. Because if I'm telling you 100% every time I take your pain away, run away from me, because that's not right. Does that make sense? Okay. Oh, it's a beautiful question. I love it. Perfect. So the idea is, you saw how we were putting the screws in. The idea of the screw is you have to have something to put the screw in, right? Okay. So osteoporosis basically makes the bone brittle, kind of like styrofoam. So think about this: putting a screw through a block of wood, and then putting it through styrofoam. When we move the spine, if I'm moving a block of bone, right, or a block of wood, the screw is not going to move, but it's through styrofoam, it's going to pop right out. Next question is going to be, so how do we deal with that? So if a patient has osteoporosis, there's osteopenia, osteoporosis, right? Based on their number, I will send them to an endocrinologist to start on a medication called Forteo. We'll put them on the medication for several months and then do the surgery and continue with Forteo after the surgery. That's how we handle that. Also, I'm sorry, Forteo. I leave that to the endocrinologists. They're the experts on that, and so I'm talking out of place if I say something like that, but I would let them handle that because there's a lot of issues with that you need to be aware of, and I'm not an expert on it, so I'm not going to say anything about that.
Acupuncture. So the question is acupuncture helpful for low back pain? And believe it or not, there's quite a bit of evidence showing that acupuncture is extremely helpful for low back pain, and not just for back pain, joint pain, nerve pain, nausea, anxiety, depression. You won't believe it. So is acupuncture effective? Yes. And it's not that it's only acupuncture that's going to help you. It's a combination. And that's what I hope that I come across with today, is there's no one light switch for pain. There's no one thing that will help you with pain. It's the combination. Anti-inflammatories, acupuncture, staying active, just moving yourself a little bit every day. A little bit, small goals. And that's the key, right? We won't conquer Rome in a day, but the small goals, if we make small goals, you'll have better relief. Yeah.
Or is that even a fair question?
No. A very fair question. So the question was, somebody who has the whole thing, bad disc, herniated disc, facet arthritis, and stenosis in their back. How do you deal with that? That's where experience comes in. Mm-hmm. You want to go to a guy or a person who can talk to you, spend time with it, and decipher what's causing you the most trouble. And sometimes it's all of them, so we're going to address all of them. You can just do the decompression for the stenosis, do the fusion for the pain, and do the decompression for the nerves. If it's just the nerves, we can just go and open a little bit and clean that nerve, right? If it's just the stenosis, we can just decompress the back, no fusion. So it depends of what your primary complaint is. If it's all of them, then you got to fix all of them. But I have to spend time with you, listening to you, examining you, and that's how you do it. That's how you do it.
But a laminectomy is something that deals with stenosis, is that correct?
Correct.
Yes, sir. Now, it deals with a specific type of stenosis, which is called a central stenosis. It's a little more anatomy here. So as the nerves travel, there are specific places that they travel through. The center, then they go out to a little freeway, we call the lateral recess, and they go out into the exit road, which is called the foramen. So it depends on where you're pinched or where you're narrowed that we're going to decompress. And that comes with experience of the doctor and doing sometimes therapeutic blocks to find out where the pain is coming from. That's why I said at the beginning of the talk, I need to talk to you plenty of time to figure out where the pain is coming from. If I cannot figure it out, I have no business being on your back. Does that make sense?
Yeah.
Okay.
I'm in the therapeutic block stage soon.
Sure, no problem. Whatever.
Thank you.
Oh, you're welcome. She gets to pick.
Time for one more question.
Okay.
Yes, sir.
So basically, education, like she said, simple baby steps, healthy diets. Number one thing I would tell you, if you smoke now, stop. And don't ever start smoking. The worst thing you can do to your entire body, really. So education about your well-being, just basic things: diet, healthy living, get enough sleep, and enjoy your life. Enjoy your life.
That's still keeping 80% of the people with the problem.
80% of people need to be educated. Yeah. Can I take one more? There was somebody back there who's been asking one. Go ahead. It depends. If the Chiari, so what he's asking is this. Now I'm going to put my brain surgeon hat on. I'm going to take my spinal surgeon hat off. So what he's talking about is the back of the head. The back of the head, behind the part of the brain comes through there. Sometimes it comes too low, and it's called a Chiari malformation, and it can become symptomatic. Okay, so the way we address that is we open back here, we remove that part of the skull that's to give it more room. If it's symptomatic, I would do it first because the real estate there is a lot more expensive, right? Okay, and then I would address the rest. The interesting question is actually in some children, sometimes some of their conditions get better with those decompressions from the spine.
So they basically fix everything downstream.
It can, but like I said, you want to, if you're symptomatic from this, you want to address that first. Just like having a problem in your neck and it's symptomatic, you want to fix this neck before you fix your back. So yeah, sort of like, yeah, it's a little more expensive, right? Yeah. You're welcome, sir. I would love to stay here all night, don't get me wrong, but thank you. Thank you all for being here. Thank you so much.